Hi, Dr. Garima here. Let's right away jump on to the next question for ADC. Yeah, I'm just oning my mic. Yep. So these are the practice questions released by the ADC on their website, and we are just solving it for you all to understand how to train your mind to solve these questions, as they can be very, very tricky, right? Of course, the question bank of the ADC is mentioned through its resources on their website, adc.connect.au, I guess. And there are a list of like 25 plus textbooks and a lot of articles. Questions from them have been compiled and published in my two books, Comprehensive ADC Book and Ultimate ADC Companion Book. You can just email me on adcwrittenmocktest@gmail.com. I'm providing the link in the description, and I can forward you the sample copies of those books. Of course, you have to also solve the mock test if you have to clear the exam, because unless you practice, how would you know how solving the paper feels like? And this is a sample of that paper. So let's start solving this. Amanda Rogers, 76-year-old, 76, wow. Presents to your surgery, she has had pain from the lower right quadrant, which has kept her up at night. So it's a severe pain. If somebody is waking you up in the night and keeping you in pain, it's a severe pain. So now, what conditions would necessitate the use of antibiotic prophylaxis for Amanda? Antibiotic prophylaxis is a very important question, and always one such question is asked in the exam. There can be more, but one at least is always asked in the exam. It can be related to indigenous population or infective endocarditis or whatever, but antibiotic prophylaxis is asked. What does antibiotic prophylaxis means? It means you have to give the antibiotics to prevent development of some other condition, because either some congenital condition is present or some medical condition is present in the patient. When you will do a normal dental procedure, it can risk damage to other organs of the body, especially the heart. So you give antibiotics to prevent that damage. That's why antibiotic prophylaxis. Understood? A good table is given in therapeutic guidelines, and let's see what the options are given to us here. Mitral valve prolapse, pacemaker, VSD, PDA, artificial hip replacement. Artificial hip replacement could be the answer, but if it's more than 2 years since it's been done, then you don't have to give antibiotic prophylaxis. And since they have not given the timeline of it, I'm going to assume it's going to be more than 2 years, so that is not my answer. Mitral valve prolapse. Any valvular defect would definitely need antibiotic prophylaxis, but prolapse is not like a defect in the valve types. And as per the American Heart Guidelines released in 2022, it's not required for prolapse. Pacemaker, no, not required. VSD, again, it is a congenital defect, no doubt. But again, if it's not indicated, like the patient is 76-year-old. If it was a severe VSD, then it would have been repaired earlier on. PDA, again, see, VSD and PDA both technically by American Heart Association does not require antibiotic prophylaxis, and the patient is 76-year-old. Like, if so far she survived this. But my choice of answer would be PDA, because that can be classified as a cyanotic heart condition, meaning there is the oxygenated and the deoxygenated blood can go through the congenital defect. VSD is also a congenital defect, PDA is also a congenital defect, but more weightage is given to PDA to receive antibiotic prophylaxis than VSD. According to me, both C and D can be the answer of choice, but they prefer D, so I will go with option D. Amanda's medical form indicates that she also has the following medical condition. So apart from that, she has more: high blood pressure, stroke 9 years ago, smoker, currently 1 pack, emphysema. Emphysema is a lung problem. Okay. Now, there is already, so we don't know if she has a heart problem or not, because the first question doesn't say she has. It just asks what condition would necessitate antibiotic prophylaxis. It doesn't mention she has that, okay? So we don't know if she has a cardiac problem or not, because the first question is not saying she has it. See how tricky they make the questions. But what does her medical form does indicate, that is high blood pressure. 155 by 95 is high actually. Like you can classify this as stage 2, I guess. Stroke 9 years ago. Smoker. Now smoker is more important here because she is having 60 packs per year history, which is quite a lot. Like 1 pack per day. 1 pack has like 10 cigarettes and emphysema. So she has a lung problem, and on top of that she is smoking also, and that to 10 cigarettes a day. That with the history of stroke and a high blood pressure, having a high blood pressure and still having cigarettes places her in a stage of severe systemic disease. Emphysema is a severe systemic disease. It cannot be mild. Having any problem with the lung compromises your breathing, so that could go into a severe systemic disease. But it's still not life-threatening. Okay, it's still not life-threatening, like it's not a constant threat to the life. So I would classify her as C, option C. Amanda indicates she's taking warfarin to prevent a second stroke. Okay, warfarin is a blood thinner. Which test is the most appropriate in measuring the effect of warfarin? Now this is the biochemistry question of the first year. The answer is straight internalized normalized ratio, international normalized ratio, INR. A normal INR should be 1 or less than that in a normal healthy patient. If a patient is taking warfarin, then between 2 to 4 is considered okay. It's not abnormal. In a normal patient, if it's between 2 to 4, then you have to find out why it is like this. There must be some underlying cause. But in a patient who is taking warfarin, then between 2 and 4 is considered normal, the INR. That is your base ratio before you do any extraction or any procedure that requires a lot of bleeding. And you should ideally be doing it 24 hours before the procedure, okay? But you would never ask the patient to stop taking warfarin. It will be always the decision of the general practitioner to do so. You take a panoramic radiograph which reveals tooth 4-8 to be carious. You assess the tooth on the image. Which radiological sign indicates the highest risk of nerve injury during third molar surgery? 4-8. Whenever there is a nerve compression, there would be narrowing of the canal over the radiograph. That is the most complicated case and has the most risk. So straight away, just remember this sentence, write it down in your book. Whenever you see interruption of lamina dura, narrowing of the inferior dental canal, that is straight answer. You don't even have to look at any other options. But let's look at the other options. Interruptions of the lamina dura of the inferior dental canal overlying the tooth. Now, superimposition of the inferior dental canal. Superimposition means they are away from each other. That's why it's superimposing. Presence of enlarged pericoronal space, that is not our concern. Periradicular bone sclerosis. Periradicular can be a little bit of concern, but that's for the bone, it's not for the nerve canal. But narrowing of the canal is because the root of the tooth is pressing over it directly. Superimposition is there away, but pressing over it is going to narrow that space. That's my option B. Your treatment plan involves the removal of tooth 4-8, but based on the film, you are concerned about the risk of nerve injury. Which additional imaging modality is most appropriate? I keep on saying in all my videos, focus on the keywords. Most appropriate in planning for the removal of third molar. Most appropriate means all the options will be correct. All will be appropriate options, but which is the most appropriate? With the advent of CBCT, straight away for it. Don't even look at anything else. The answer is E, cone beamed computed tomography. So MRI is not for bones, it's mostly for the soft tissues. LATSF won't help you much. Periapical radiograph, no. It can be helpful, but a 3D image is always a better because you have already done the OPG and you want an advanced imaging modality to know the exact status in a 3D format. So CBCT is the answer. So I hope you have understood. Very important question. Not only this question would be asked in your part 1 exam, it is very probable that it would be asked in your part 2 communication OSCE as well. They love giving you medical history, complicated third molars, and asking you how you're going to treat this patient if he has some heart problems, or when you're going to give and when you're not going to give antibiotic prophylaxis. So this topic covers many other topics within its umbrella. I would suggest you to go ahead and read all these topics. If you have already read, revise it, write notes about it. And if you have any other questions, just leave it in the comments. Have a nice day. Bye-bye.